Now let's talk about congestive heart failure. So the basic definition for congestive heart failure is basically the impairment of the pumping action of the heart. Therefore, it basically is a decrease in myocardial contractility. So a patient can have left-sided and right-sided or right-sided heart failure. So they can have either or both, right? So left-sided is basically when the left ventricular function of the heart is no longer good. So it causes left ventricular dysfunction. On the other hand, right side means that the right ventricle is not functioning well, or right ventricular dysfunction. The most common cause of left-sided heart failure includes CAD, MI, cardiomyopathy, valve disorders, and hypertension. So what happens in left-sided heart failure is that the left ventricle starts failing. Therefore, blood starts pooling and it goes through the left atrium, and then it causes some congestion in your pulmonary vessels, causing pulmonary edema. So this is basically a result of the diminished ventricular function. So it makes the blood pool, right? And then it backs up to the left atrium and backs up to the lungs. So a lot of its symptoms, right? So left starts with an L, and the symptoms are more lung related. So lung starts with an L as well. So that's an easy way to remember. So what are those signs and symptoms? So because of the hypoxia or low oxygen levels, it causes some changes in the mentation of the patients. So you see restlessness, agitation, fearfulness, and on the cardiovascular system, you see tachycardia or increased heart rate, and you can also see blood pressure changes. So sometimes, especially towards the end of heart failure, you'll see patients developing low blood pressure. And in the pulmonary aspect, so this is what you're going to see a lot. These are going to be the more obvious symptoms in the left-sided heart failure. So you can see respiratory problems. So the patient is having a lot of shortness of breath. They have pink and frothy sputum. And then skin-wise, they will have pale, cool, and clammy skin. So this is typically what a patient with left-sided heart failure will look like. Right? So there's a lot of restlessness, confusion, orthopnea, or basically shortness of breath or difficulty breathing with different positions, mainly when the patient is laying down. Again, as mentioned earlier, tachycardia, you will see some exertional dyspnea, so basically shortness of breath or difficulty breathing with activity or exertion, and they experience a lot of fatigue, cyanosis, right? The blue discoloration, especially noted in the mouth area. You also have paroxysmal nocturnal dyspnea. So this is basically shortness of breath that mainly happens at night. And when you're measuring your hemodynamics, which at this point you guys are not really responsible for knowing that, when measuring that, you will see elevated pulmonary capillary wedge pressure. And again, a lot of the symptoms are pulmonary or lung related, right? So you'll see coughing, crackles, so the sound in the lungs is not clear. You'll hear crackles, you'll hear wheezing, and they tend to have blood-tinged sputum and tachypnea or breathing fast. So for right-sided heart failure, the common causes include CAD, MI, cardiomyopathy, and pulmonary disease or pulmonary congestion from other sources. So how does it happen? Well, what happens is this specific heart failure, your right ventricle starts failing, and it causes the blood to back up to the right atrium, right? And so then the fluids from the right atrium will back up in the systemic veins. So the right ventricle, which is often enlarged and stretched at this point, right, causes the pooling of the blood in the right ventricle going to the right atrium, and again causing pressure and congestion in the vena cava and causing congestion in the systemic circulation. So the way I remember the symptoms for this, right? So right-sided, right starts with an R. So the symptoms often includes the rest of the body starts with an R, right? So the rest of the body, which usually includes your extremities. So signs and symptoms include peripheral edema or swelling in the extremities, jugular vein distension or the distension of the jugular vein, and you also see a lot of the GI tract vascular congestion, which causes hepatomegaly or enlargement of the liver, and splenomegaly or enlargement of the spleen. So when caring for patients with heart failure or congestive heart failure, what are the labs that we need to analyze and monitor? So these are the main labs that you want to look at whenever you're caring for these kinds of patients. So you want to look at your cardiac enzymes. So basically these are blood work that indicates your cardiac status. We're going to be more specific down the road, but in the specific, for now, it's good to know that you need to know your cardiac enzymes. Your CBC or complete blood count, hemogram, and mainly for heart failure, a very important blood work that you need to know is the BNP or brain natriuretic peptide. So this peptide or this BNP is basically secreted by the heart muscle cells in the ventricles as a response from the stretching. So the more the heart overstretches, the more BNP is produced. Therefore, towards when you have heart failure, you're going to see them a lot coming in the hospital, and their BNP are really high, and sometimes during exacerbations they can be even in the thousands. And I just want to look back and go back to the right-sided heart failure symptoms. And so this is a representation of what a patient with right-sided heart failure will look like. Right, so here we have a lot of swelling in the lower extremities, right, because of the peripheral venous pressure, and then often their spleen and liver are enlarged. So sometimes they can have secondary chronic pulmonary problems from all the backing up or congestion, but mainly the congestion is in the rest of their body. So you have distended jugular veins right over here, and then swelling in their hands, fingers, and again, lower extremities. Sometimes they can have a lot of weight loss, although they may have distended abdomen. Generally, they look malnourished, and they may have a lot of complaints, abdominal complaints. So how do we treat CHF or congestive heart failure? So pharmacologically, this is how we treat CHF. So again, we treat the acute pain with morphine, right? And then we also use fluid volume management with the use of diuretics. So mainly we use loop diuretic and potassium sparing diuretics. And our goal for treatment is afterload reduction. So what kind of medications do we like to give for afterload reduction? So as you may remember from previous units, we use ACE inhibitors, beta blockers, alpha-1 and beta receptor blockers, calcium channel blockers, nitrates, and vasodilators to reduce afterload. The first line of therapy, however, for this are your ACE inhibitors and your ARBs. Again, the first line therapy to reduce afterload for patients with CHF are ACE inhibitors and ARBs. In addition, we also use platelet aggregation inhibitors. So examples of this are your aspirin and clopidogrel. So why do we need platelet aggregation inhibitors? In CHF, what happens is because of the decreased ability of the heart to pump, the blood is more stagnant. So there's not a lot of blood flow. So whenever your blood is not flowing well, right, it's not moving, there's a higher risk for clotting. Therefore, it is very important to put our patients on platelet aggregation inhibitors to prevent them from developing complications related to that stagnant blood flow. So they become at high risk for developing clots such as DVT, PEs, MIs, and embolic strokes. In addition to platelet aggregation inhibitors, we also use anticoagulants. So what are the examples of anticoagulants that we use? We use warfarin and enoxaparin. And again, why do we use it? Well, because of the prothrombotic or hypercoagulable state that's causing venostasis, right? So the blood is staying in one area, and it's caused by the high pressure and low flow state, and sometimes immobility as well. Because of that, they're at a higher risk for developing clots, and that's why we put them on both platelet aggregation inhibitors and anticoagulants. We also use lanoxin or digoxin in CHF. So this is the oldest group of cardiac drugs, but this is no longer used as first-line drug. So back in the day, this used to be first-line drug for CHF or heart failure. So this specific drug, digoxin, is from a pharm class called cardiac glycoside. So how does this medication work? So this medication works by increasing the vagal tone or activity of the vagus nerve, which enhances, right, or strengthens myocardial contractility. This specific medication can be given in the forms of oral, right, PO, or IV. What are the therapeutic effects of digoxin? Therapeutic effects include increase in myocardial contractility. So because there's an increase in contractility, this is considered a positive inotrope. This, however, decreases the heart rate. So the heart rate will go down. So this is considered a negative chronotrope. Indications for digoxin include heart failure and some dysrhythmias. And then when resting heart rate is not under control. So this is basically for fast heart rhythms because it decreases the heart rate. So some contraindications or reasons why we shouldn't put patients or we shouldn't give patients digoxin. One is an increase in serum drug level. So when the patient is basically overdosed, right, or the toxicity is high, and also in the presence of hypokalemia or low potassium levels. This is also contraindicated in some cardiac dysrhythmias, mainly second and third degree heart block, because this kind of heart blocks or dysrhythmias are often slow, right? So then we know that digoxin slows down the heart rate. Therefore, if somebody already has a slow heart rate, then we don't want to give it to them, right? Because it can make it worse. When taking care of patients taking digoxin, we need to evaluate, we need to monitor and analyze the following lab values. So one, something that you have to remember is the therapeutic digoxin level. So therapeutic digoxin level starts from 0.5 to 2. And then next is your potassium level. So potassium level typically needs to be within normal range or 3.5 to 5. In addition to that, it is very important to monitor and analyze your renal function. So basically, we assess your BUN and creatinine because this medication, when given to somebody with decreased renal function, it can actually cause increased toxicity. As you all know, patient education is very important, especially when it comes to this medication. So what are the things that we need to educate our patients on? We need to make sure we educate them on the dosing of the drugs, right? The side effects, how to measure and when to measure their heart rates, right? And also, what are the blood work that they need to make sure they have, right? They also need to have an idea of what their levels are. So blood work necessary include their digoxin level, their kidney function, which are your BUN and creatinine, and their potassium levels. So in case of overdose or toxicity, so usually if that happens, the patient experiences bradycardia or low heart rate. They have headaches, dizziness, confusion, and there's some changes on their EKG. So what do we do when a patient develops toxicity or their overdose on digoxin? The acronym to remember is SAD, right? So when they overdose on digoxin, it is SAD. S stands for stop the drug, right? Because the drug cannot be dialyzed, we have to treat it symptomatically. A, start for the antidote. So we need to give the antidote. And the antidote that you have to remember for this specific drug is Digibine or digoxin immune fab. Digoxin immune fab is an antidote for digoxin. And lastly, we have to remember that digoxin levels will be inaccurate for the upcoming 3 to 5 days or even weeks after the said overdose, or toxicity. So it is very important to do a very thorough cardiovascular assessment of your patient. We need to know when would we hold a dose. So when would we not give the scheduled dose? So typically we would hold the dose whenever the patients are experiencing toxicity and or their heart rate is less than 60. Next, let's talk about cardiac dysrhythmias. So obviously you guys have to read your outline, but in here I just want to emphasize the following information. So there are many things that influences our electrical conduction of our hearts, right? So there are many factors that can affect that. So mainly there's also what you call myocardial irritability, or the irritability of the heart. So what irritates your heart cells? So reasons that cause myocardial irritability would include hypoxemia, right? So low oxygen level in the blood. Then you have electrolyte imbalances. So primarily your potassium and magnesium, and that's why I keep on emphasizing you need to monitor, you need to check your potassium and magnesium, especially if you have a new onset of dysrhythmias. And lastly, your acid-base disturbance or imbalance. So whenever your blood pH is too high or too low, that can actually trigger cardiac dysrhythmias or abnormal heart rhythms. So depending on the heart rhythm that we may encounter, sometimes it is necessary to treat it pharmacologically or use drugs to be able to control that rhythm. When giving those kind of medications, it is very important to know the likely side effects of antidysrhythmic agents or drugs. So the main side effects that you will see when it comes to antidysrhythmic drugs include dysrhythmias. So this is what you call proarrhythmia. So they have the proarrhythmia effect, meaning these medications specifically treat dysrhythmia. But unfortunately, sometimes while giving this medication, it can also cause a dysrhythmia. So it treats the problem, but it can also cause the problem. Also, another side effect, changes in your vital signs, mainly your heart rate, your blood pressure. And sometimes with specific drugs, it can cause confusion and pulmonary fibrosis or scarring of the alveoli in your lungs. So that's when the lungs become stiff and scarred. And knowing what we know about antidysrhythmic drugs, these are the nursing actions or nursing interventions that we have to do. Again, mainly we need to assess for the cardiac rhythm, right? Like with anything else, if we're treating something, we need to assess before and after we treat that. And in some cases, we even have to monitor the cardiac rhythm while giving. So we need to actually see the rhythm while we're giving that medication. In addition, oxygenation, right? We need to make sure that the patient oxygen is good. So sometimes we need to give oxygen supplementation. We need to check the drug levels depending on what medications we're giving. Checking your electrolytes, our acid-base balance, while by using our ABG or arterial blood gases. And then again, patient education. So we need to educate our patients regarding the effect of the drugs, the side effects, and the symptoms associated with the dysrhythmia, and some pertinent lab work. So there are many antidysrhythmic medications. So for your course, you just basically have to know that there are different classes, right? So you have class 1, which includes the fast sodium channel blockers. You have class 2, which includes the beta blockers. And you have class 3, which include the potassium channel blockers. And so mainly the focus is your class 3. So you're going to see this class of antidysrhythmic medications quite often in the clinical setting. So class 3 antidysrhythmics are the potassium channel blockers, which are used to mainly treat ventricular dysrhythmias, but also they're used for some atrial dysrhythmias. The medication or the prototype drug that you need to know for this class, right, class 3 potassium channel blockers, is your Cordarone generic amiodarone. So amiodarone is a medication that you need to remember, and this medication is often given for atrial dysrhythmias, and during a code situation, it can also be given for ventricular dysrhythmias. Last but not the least, these are the general nursing actions when caring for patients with dysrhythmias or they're taking antidysrhythmic medications. So again, assess your cardiac rhythm. You follow, you analyze, you look at the trend of your heart rate and blood pressure. You need to assess for the response to the medication. So it's not enough to just give the medication. You need to go back and evaluate, right? You need to reassess to make sure, one, is the medication working? And two, did the patient develop any side effects? So we need to evaluate for therapeutic effect and side effects. Again, we need to follow, analyze those labs because those labs will give us cues about what's going on with our patient. So the labs that we need to know include CBC, electrolytes, renal function, and the drug levels if applicable. And again, patient education. Again, we have to talk about what's the effect of the drug, what do they anticipate will happen to them when they take that medication? What are the things that they may be feeling once they take the medications? What are the possible side effects? What are the symptoms that are associated with that dysrhythmia that they have or that we're treating? What are the blood work that they need to have? And again, the importance of following up and really keeping up with the doctor's appointments and taking the medication as ordered.